Hello, everybody in podcast land. I'm Dr. Ted Thatchencary, and this is MD Roundtable, a podcast about collaborating and learning from other healthcare professionals from all over the globe. We are all so much more connected due to technology. We have so much to learn from each other. Thanks for joining us today at MD Roundtable. This is a very exciting episode as we are featuring Dr. Giles Peek, who is an ECMOlogist and professor of surgery and pediatrics at UF Shands Children's Hospital Congenital Heart Center at UF Health in Gainesville, Florida. He is also an active member of ELSO since 1994. Welcome to MD Roundtable, Dr. Peek.
Thank you very much for inviting me, Ted.
Of course, glad to have you. First off, if you don't mind, Dr. Peek, if we could start off with your journey. Where did you grow up?
I grew up in the southeast of England in a port town called Shoreham-by-Sea.
I see. Great. And who was your biggest childhood influence on becoming a surgeon?
Probably my father, I think. He was a dental surgeon in general practice, but he also used to work in the local hospital in the maxillofacial surgery department because he trained with the guy who became the chief. And in those days, they didn't have people to run the service. So I remember as a small child him taking calls from the trauma department, what used to be called the casualty ward in those days in the UK. And they're always the same. It's always, yeah, Lefort fracture, yeah, how's the airway? Yeah, okay, I'm coming. And I worked in the dental lab as a child, sweeping up to earn a few extra coppers, which made me decide that I didn't want to be a dentist. But the idea of being a surgeon, I found quite attractive.
That's great. Dr. Peek. Where did you end up doing your university and your specialty training? Was it in the UK itself?
Yeah, so rather prosaically, I ended up going to the same medical and dental school that my father went to, which is King's College Hospital School of Medicine and Dentistry, which has two campuses. You start off on the Strand in central London, not far from Trafalgar Square, and then you end up at Denmark Hill in South London, which was in those days a rather deprived neighbourhood next to Brixton, which was a rather violent neighbourhood in those days. When I got there, it was 2 years after the Brixton riots, and the police wouldn't go there. So it was very much a inner city kind of experience, but with also world-class teaching hospital stuff. It was still is the leading liver transplant centre in the UK, for instance.
I see. Great. And how did you end up in the U.S.? Did you do further training in the United States?
No, I came to fill a space that there was no Americans to fill. And my wife is a dual citizen, so
I see.
We have family over here, so it was not completely crazy. But no, I did not. I was a well-established surgeon with an international reputation when I came here.
Fantastic. This episode is brought to you by ECMO Advantage. High-quality ECMO doesn't just happen. It comes from thorough training, the right policies and procedures, and experienced support. That's where ECMO Advantage comes in. Whether you are launching a new program or optimizing an existing one, ECMO Advantage provides expert-led consulting, industry-leading high-fidelity simulation, and experienced ECMO specialist staffing. Since 2007, ECMO Advantage has partnered with hospitals to build confident teams and achieve improved patient outcomes. Ready to strengthen your ECMO program? Visit ECMOadvantage.com to schedule a call today or join an upcoming ECMO course in Tennessee. Because when the next patient needs ECMO, being ready makes all the difference. ECMO Advantage, helping patients thrive, not just survive. In your journey with medical training, what have been some of your biggest challenges that you've had to overcome?
I wouldn't say so much with my training. I feel lucky to have been trained by some of the people that established the specialty of congenital heart surgery, starting with Magdi Yacoub, Chris Lincoln, John Pepper, Mark de Laval, Martin Elliott, Bill Braun, David Barron, who recently left Toronto to go back to the UK, and to work with the people that established ECMO in the UK, Andrew Sosnowski and Richard Furman. I would say that my training was fairly straightforward. And Peter Bell, of course, was my academic mentor, who was the president of the Royal College of Surgeons. I think I won't say it's been a problem, because it's been, what my career's been all about, is when I first started in 1994, ECMO was something which was an established treatment for babies with respiratory failure in the United States. Now it is a global treatment which is used for patients with respiratory failure, cardiac failure of all age groups, including to resuscitate people with cardiac arrest, including in the community. Mm-hmm. And I think the best part of my career, if you like, and also the most challenging, is doing the research and writing the papers that convinced people that it wasn't a crazy experimental treatment, but it was actually standard of care. And so that's been what my career has been about. The surgery I love, and I'm pretty good at it, and it pays the rent, but I don't think that that's my main achievement.
I see. Great. Well, thank you for sharing that, Giles. Well, with that being said, let's dive into the topic of ECMO for our listeners a little deeper. Just sort of a 40,000-foot view, Dr. Peek. Can you explain what extracorporeal membrane oxygenation is and why it is important for our listeners?
Sure. So, to recite a sentence I've written at least 10,000 times, extracorporeal membrane oxygenation, or ECMO, uses cardiopulmonary bypass technology to support patients with severe but potentially reversible failure of the cardiac or respiratory or both systems whilst they recover, and can also be used to support people while they bridge to either a decision, another device, or directly to transplant. So it's really something that we use in patients that are too sick for intensive care units, and there are very few top-level intensive care units now around the world in any acute specialty that don't have ECMO capability.
Right. Great explanation. How long has the technology been around?
So the first successful patient was done in 1972, but it didn't really reach mature technology status until, I would say, the early noughties. And although the technology was roughly what we have today at that point, I would say that it didn't really become accepted outside of the neonatal arena until the combination of the H1N1 pandemic and the CESAR trial being published in 2009. And I think that's really when most people think it was invented.
Mm-hmm. I see. Okay. Great. Can you give us a few examples, Dr. Peek, of patients that might need ECMO?
Sure. Well, as I said in my preamble, you can use it to support anybody with a severe but potentially reversible cause of cardiac or respiratory failure. And so take your pick. The most recent example I would say would be COVID, which caused severe respiratory failure. Influenza causes severe respiratory failure. Bacterial pneumonia causes severe respiratory failure. And then into the cardiac arena, you have any kind of cardiac failure. So, for example, you could have a severe beta blocker overdose. You could have cardiomyopathy. You could have septic shock. You could have arrhythmogenic storm, cardiac arrest. Perhaps the most interesting thing, which perhaps people don't think of in terms of cardiac arrest, is patients with hypothermic cardiac arrest. So if you, for instance, were swimming in the sea until you became exhausted and drowned and cooled down before you became exhausted, and then were then rescued in a reasonable time, or if you were buried in an avalanche and you weren't immediately killed by the fall, or and you didn't obstruct your airway, but you cooled down and then had a cardiac arrest and were rescued, even though you may have been arrested for several hours, you can then be successfully rewarmed and reanimated with extracorporeal membrane oxygenation. And there are numerous miracle case studies that use the technology in both the medical literature and the popular press.
Yeah, that's amazing. Just the utility of what you can do with it now. If we could just talk about the different configurations? What are the different types of configurations we have with ECMO?
So there are two main setups, and like the Monty Python joke about the Spanish Inquisition, there are three main configurations. So there's vena venous and vena arterial, and there's a hybrid form of those where you have a bit of vena venous and a bit of vena arterial. But there's also another kind of form which is becoming increasingly popular, particularly in adults, which is called venopulmonary. So vena venous is the classic respiratory support, and blood is drained from the venous circulation, oxygenated, CO2 is removed, it's rewarmed, and then it's replaced in the venous circulation. So there's no net removal of blood because it goes in and comes out the same amount. And basically, it means that your mixed venous oxygen saturation goes up, above 80, maybe into the 90s. And so the right to left shunt through your diseased lungs becomes irrelevant, and then you can reduce the airway pressure, and the ventilator-induced lung injury is killing you, and then you have a chance to get better. Vena arterial ECMO drains from the right atrium one way or another and returns to the aorta one way or another, and obviously, therefore, the right heart is empty, there's less blood going through the lungs, and the circulation is supported. And then, you can mix and match all of those things into various hybrid forms. But those are the two main technologies.
Great. Thank you for explaining that. This episode is brought to you by Vigilant Software. It's hard to believe that in 2025, 35% of medication administered in hospitals still rely on handwritten labels. In fact, studies show that 1 in 4 medication errors are directly tied to poor or missing labels. Now, Vigilant Software delivers a comprehensive suite of automated printing solutions, eliminating handwritten labels across the hospital, reducing errors, and unburdening clinicians to give them back more time for patient care. With one quick barcode scan or touch of a button, Vigilant prints accurate color-coded labels in seconds. If your hospital still relies on handwritten labels for syringes, IV tubing, or infusions, Vigilant offers no-cost trials with proven benefits like saving 4,000 hours of nursing time spent on medication labeling each year. Connect with Vigilant directly at www.vigilantsoftware.io or click on the Schedule a Demo link in the upper right corner on their website. I want to thank Vigilant for sponsoring this episode of MD Roundtable. Cannulation be done by intensivists in the ICU or in the emergency room?
I've taught many intensivists to cannulate, and I think that for adult respiratory ECMO, I think that intensive care-led cannulation works extraordinarily well in grown-ups. I think that it also works pretty well for cardiac patients as well. I think in children it's more problematic. I think that you often need surgical cannulation. I think the most important thing to say about ECMO is that there are very few people that can actually do everything themselves, and you need a number of different people to do ECMO successfully. So the first person that you need is an ECMO specialist, and that is the person who basically looks after the patient and the pump, because it's obviously a integrated system. And I would say that ECMO care should be seen as a whole system of care. It's not just a bolt-on adding to the conventional intensive care that the patient's having. And then the second thing you need is somebody to take responsibility for the overall patient care and for what the ECMO specialist does. And that person is what I term the ECMOlogist. And there are an increasing number of us in the world, although we are yet to be officially recognised. And I would say an ECMOlogist is got a background and full training in one of the related professions.
Mm-hmm.
So that could be pediatric surgery, it could be congenital heart surgery, it could be adult heart surgery, it could be adult intensive care, it could be pediatric intensive care, it could be neonatology. But you have significant both training and experience in ECMO. And I would suggest that to be an ECMologist, you also need to be an ECMO specialist. So you need to have undergone that training and done some of that work to understand exactly what it is. And you can also, I think, ideally build and prime a pump yourself, even if you can't do it as slickly as the ECMO primer, who's another person that you need. Now, the ECMO primer obviously builds and primes the pump and establishes the patient on ECMO. And the final part of the puzzle is the ECMO cannulator.
Mm-hmm.
Now, the ECMO cannulator doesn't necessarily have to be an ECMologist. They could be an intensivist, they could be an interventional cardiologist, they could be a general surgeon, they could be any one of a number of people that knows how to put a pipe in a blood vessel. And I think looking at those job functions in a kind of modular way, first of all, allows people to contribute to the patient care. But secondly, hopefully allows understanding what their function is, allows them to function as part of a integrated team. So if you're an interventional cardiologist, for instance, and you're putting a respiratory patient on ECMO, and that's a model that works in a peripheral hospital not far from me, you probably don't understand necessarily how the whole patient care fits together, and the ECMologist in this setting can't cannulate herself, but can manage the patient. So, it's I think it's a team game. It's the biggest team game in medicine, and I think that recognizing the contribution of other people in the team is really important. So what I always say when I'm teaching intensivists to cannulate, or people that aren't surgeons, is that you need to make sure that you've got a surgeon that will be understanding if you call them, and that understands what's going on in general with ECMO. And so having a surgical friend that you've discussed things with can be very helpful if you have a complication.
Yeah, very well said, Dr. Peek. Yeah, definitely a multidisciplinary team approach when it comes to ECMO. Moving on, what are the specific criteria to qualify for ECMO? Because I know during COVID, we were in an ECMO center where I practiced, but we would, have tertiary referral centers where we would call, and they would kind of see if the patient would qualify.
Yeah,
And a lot of times they didn't qualify, right? And we just had to accept that.
sure.
But
Well, I think that's a really good question. And of course, the goalposts of what is an acceptable patient for ECMO change all the time. And we learn all the time. So during H1N1, for instance, we said we were not going to ECMO anyone who weighed over 150 kilos. Now, we've subsequently discovered that for respiratory failure, actually being morbidly obese is actually a risk factor for survival, which is strange but true. And so, that maybe was not the smartest thing that we ever did. I think that there are two issues with what the selection criteria are. One is down to reversibility, and two are down to resource use and resource availability. So I think having a hub and spoke network improves availability. So during COVID, ELSO produced some guidelines saying that you shouldn't start a new ECMO center during COVID because we don't think it will improve survival.
Mhm.
And that indeed proved to be the case in the United States, where people established new ECMO centers, did not take any advice from established ECMO centers because they were so smart they didn't need to have any advice, and their outcomes were appalling. Now, in the Far East, not so much Far East, sorry, in the Asian, the Indian subcontinent, a number of new ECMO centres were set up, but they did it with a mentorship scheme from established centres. And the SWAC ELSO group, with a few collaborators from the rest of the world, actually wrote this experience up. And the outcomes in the new centres were just as good as in the other centres. So, and we've duplicated that experience in Florida with the hub and spoke model with peripheral hospital in the Panhandle, which is doing extraordinarily good work with excellent outcomes. And it's not rocket science. If you imagine there was no such thing as an intensive care, and the big teaching hospital down the road had just bought its first ventilator and was using it successfully, and you decided that you were going to buy a ventilator, and because you're an anesthesiologist, you know how to put an ET tube down, so you don't need any help.
Mm-hmm.
You're not going to do as well with it as the people that have actually spent some time working out how to use it. So I think that access is an issue. In terms of reversibility of respiratory failure, for instance, when we did Caesar, we basically said that you had to have had less than 7 days high pressure ventilation. Now, that was because we believed and we had evidence to support the idea that if you had more than that, your outcomes were not so good. I'm sorry about all these texts. We've got a patient just about to go to the OR. The outcomes would not be as good, and so we didn't want patients. We didn't want patients that weren't going to survive. Now, what we've discovered subsequently was that whilst short-term ventilation improves survival, if you basically wait for the lungs to recover, they usually will. And this has been coupled with the more willingness to bridge patients to lung transplant. So when I first started and we were establishing what adult ECMO criteria were, need for lung transplant was an absolute contraindication in the UK because nobody would allocate, or the official organ allocation system would not allocate lungs to patients that were on ECMO because it was felt to be unethical. Now, of course, ECMO is used as a bridge to lung transplant as a matter of course. So, that's not the issue. But I think that bridging patients to lung transplant has taught us that we can keep patients on for a really long time and that we can wake them up and mobilize them. And lo and behold, a lot of those patients will recover. So I believe that there's a rule of thumb that for every day over 9 days of ventilation, of high pressure ventilation, you buy yourself about another week on ECMO to recover.
Mm-hmm.
So, if you just wait, the patient will usually get better. And, the world record is just under 2 years for ECMO with recovery in a child, which is held by Hopkins.
Wow.
And we last year had a patient who recovered after 8 months on ECMO with severe necrotizing pneumonia, polymicrobial pneumonia. And, it's a case of resting the lung and rehabilitating the patient, which is something we learned from bridging to lung transplant. So having a patient that's awake, either extubated or on a tracheostomy, breathing spontaneously, maybe with a bit of CPAP, pressure support, and then gradually, reducing that down to nothing, and mobilizing, doing PT, eating normally, that kind of thing.
Great. Fantastic. What percentage of your consults at your institution end up on ECMO?
Well, what's the denominator? So of our total work, I would say it's a fraction, because most of our work in the Congenital Heart Centre, unsurprisingly, is congenital heart surgery.
Mm-hmm.
So if the denominator is people who have ECMO consults, I would say that probably 2/3 of them end up on ECMO. In the UK, we had a national service, and I've been gone for 10 years, so it may have evolved. But I would say that we probably accepted about 1/3 of the patients that were referred. But it depends very much on what people are asking. So, for instance, if there's a national referral service and everyone is aware of it because of the media coverage with COVID and H1N1 and stuff, and all these success stories, you are going to have the discussion where you go to some family and say, "I'm really sorry, but your relative is dying. There's nothing more we can do." And then the relative will say, "Well, what about ECMO?" And you say, "Well, okay, I'm happy to discuss with the ECMO centre, and they can decide, whether they think it's okay or not."
Mm-hmm.
And then you phone and say, "I've got a 98-year-old with stage 4 disseminated cancer of the kidney, which has metastasized to the brain, the bones, the liver, and so on and so on and so on. And then the ECMO centre can say, okay, I don't think that's a suitable candidate. Thank you very much. So then you go back to the family and you say, I spoke to the ECMO centre and they really don't think that ECMO is going to change the outcome. We're very sorry. So, when you have that framework, you're going to have a lot more. You're going to have a lot more referrals where actually they're just ticking a box that they've referred for ECMO and the patient's not suitable. So it very much depends on what the framework is.
Right. You sort of alluded to like who wouldn't qualify, but can you sort of elaborate as to who would not qualify for ECMO?
Yeah.
There are certain conditions, right, that would exclude you.
As time goes on, we kind of have fewer and fewer contraindications. Massive intracranial bleeding is now no longer a complete contraindication because neurosurgeons have successfully operated on patients on ECMO, and stopped the bleeding and relieved the swelling of the brain and stuff. So that changed. That used to be the only massive contraindication. I think the main thing really is potentially, or rather, irreversible disease in a patient who is not a bridge to anything,
Mm-hmm.
because then you end up stable on ECMO and you're not going to recover, you're never going to get better, and you just stay on until you die. And I have actually had a patient who asked for his ECMO to be withdrawn in that situation. There are massive pressure on ECMO teams to put people on ECMO just because without ECMO they will die. But actually, there are things that are worse than death. And I think a prolonged death where nobody can admit to the patient that they're dying is a situation I would not want to find myself in. And it's extremely horrible when you have to look after a patient like that. And I do everything in my power to try and avoid that. Sometimes, of course, you end up with a bridge to decision where you think that somebody is maybe a transplant candidate, and then you have to put them on, support them, and then you find that they don't actually measure up and they're not a transplant candidate, and then you have the same issue. You have to withdraw ECMO support in that patient as they're not going to recover. Disseminated cancer that's untreatable, I would say, is a contraindication, although that can change. That could easily change. You can imagine a scenario where these tailored antibody-mediated anti-cancer drugs, become a viable thing. And I know that experimentally it is, or gene therapy or something. And then you could see actually that might be our main thing that we do is we put people on ECMO to support them while they have that therapy. Mm-hmm. So I would say that keeping the idea that there's got to be potential reversibility and there's got to be an out is important. There's got to be a destination strategy. Severe aortic incompetence is perhaps the only thing that's an absolute contraindication in the cardiac world because the afterload from the pump floods the heart and floods the lungs. But again, that also depends on the scenario because you could have a patient with torrential aortic regurgitation due to endocarditis that you're going to take straight to the OR and then bring them out on ECMO after you fix the valve. Mm-hmm. Or you could have a scenario where you had a patient with torrential aortic incompetence that could be suitable for TAVR, which then makes the rest of the support work. So those are the main things.
Great. Thank you for clarifying that. Having said that, what are the risks to ECMO?
Oh, let me just circle back to contraindication.
Sure.
I would say that futility is a contraindication, although I'm using the term medically rather than legally, as I understand that there are a number of US states where futility is not a concept that's recognized. So I think you define it physiologically by established multi-organ failure. So I think if it's too late and the patient is mostly dead or dying, then I think that ECMO is not going to reverse that process. That's quite a subtle judgment, though, as there are degrees of multi-organ failure which you can reverse. So in terms of risks, the cannulation itself is a risk, and you reduce that risk by, I think, using imaging and by being experienced and by being educated. So ELSO produces a whole number of educational resources, including the Red Book, which we produce every 5 to 10 years, and also several online courses. The Adult Foundations and the Peds Neo Foundations are good examples of this. I think that aside from the cannulation, the real main risk is bleeding and also clotting, because the ECMO circuit is quite thrombogenic, and so we use anticoagulants, and the balance between those two things brings you most of your problems related to ECMO.
Right. What have the studies shown regarding survival rates for ECMO?
Yeah. There are 3 studies in neonatal ECMO. There's the modified Play the Winner study that's done by Bartlett, the Play the Winner study that Bartlett did originally, and then the modified Play the Winner study that Pearl O'Rourke did, and then the UK collaborative ECMO study that David Field did. And basically what that shows is that compared to the state-of-the-art treatment at the time, as these were all done in the late 80s, early 90s, ECMO improves survival compared to conventional treatment. Now, this was in the pre-nitric era, so you take that with a pinch of salt, and the need for neonatal ECMO has decreased enormously since nitric oxide came in. But basically, the David Field study, and I looked after the patients in that study. I was a junior fellow in the department while that study was going on. The number needed to treat was 3. So basically, you save 1 patient for every 3 that you treat. Now, I still think that that study stands, because if you think about the treatments for severe respiratory failure using the lungs, even with nitric oxide and proning and surfactant and things, you're still aggressively ventilating a lung that is injured. So ECMO is still the only treatment that allows the lung to be rested rather than injured continually. So I think that kind of gives you an idea of when you should use it. Now, in pediatric patients, there is no randomized controlled trial. There's a case control study by a doctor called T.P. Green, which shows improved outcome. But again, that was done in the 90s, and so is, you can see it as historic, but that's the best evidence there is, other than case series. In adults, there's my study, the CESAR trial, and then there was a trial following that, which was called EOLIA. CESAR did show a positive outcome with ECMO. The number needed to treat was 6, so we say 1 patient for every 6 that we treated. Alain Combs' study, EOLIA, did not show a survival advantage in the primary outcome, which was death, but they allowed crossover. They wanted to improve on the perceived problems with the design of CESAR, which allowed conventional treatment by the ECMO team in patients that they felt were not sick enough. So they, obviously following CESAR, they couldn't have death as the endpoint without crossover. So they allowed crossover between the groups. And so the sickest patients in the conventional arm crossed over to ECMO, and a number of them were saved thereby. The secondary endpoint of EOLIA, which they should have made the primary, which was treatment failure, they did actually show a significant difference between the groups. So there was lots of mental gymnastics in the New England about Bayesian analysis, and it was a positive study, really. And I think it was a positive study, but really you have to look at the secondary endpoint to get that impression. Now, when you do a meta-analysis, an individual patient meta-analysis between the CESAR patients and the EOLIA patients, based on treatment delivered, you find an enormously positive signal in favor of ECMO survival. So you kind of run out of zeros on the p-value. So that's for respiratory. For cardiac, there's been a number of really nice ECPR studies, mostly led by my Czech colleague Jan Bihalavek, who is a cardiologist, adult cardiologist, which again shows not enormous statistical improvement, but definitely very good signs of encouraging outcome. And this has been repeated a number of different people. And I think that ECPR is becoming a standard thing. And I think that particularly for patients that are in ventricular fibrillation, who have a potentially reversible lesion and can go straight to the lab and have that opened up, I think those patients it's going to become very much standard of care in most large university medical systems around the world. And already you can have community ECPR in London, Paris, and anywhere in Holland. Anywhere in Holland, not just in the big cities. So, that's very impressive.
Yes, that is very impressive. That was actually my next question was ECPR. So if you could just for the audience kind of describe what ECPR is.
So ECPR is basically putting somebody on VA ECMO while they're in cardiac arrest. So it's extracorporeal cardiopulmonary resuscitation. Now, this is something we've been doing in congenital heart surgery since the 1990s in centres that had ECMO. Now, we didn't know it was called ECPR. We just called it crashing on ECMO. And the survival in patients with primary cardiac disease, like congenital heart surgery patients that have a cardiac arrest, is extremely good. It's usually in excess of 50%. So, like all things, once ECMO was invented in 2009, the cardiologists started to become interested in it because there was all these machines everywhere, and they thought, we could use this to support our patients. So, people like Jan and Dimitris Yiannopoulos started using it in patients who'd had a cardiac arrest. And going back to the original indications for ECMO, as long as the indication for cardiac arrest is potentially reversible, then it can be successful. And as long as the patient hasn't had severe neurological injury before they get resuscitated, so they need to have bystander CPR, witness arrest, bystander CPR, and a reversible rhythm, so VF basically, and not be a million years old. And so, those are potentially reversible patients. And in conjunction with a strategy of taking the patient straight to the cath lab to open up any vessels that are openable, it can be a very powerful strategy.
Yeah, very intriguing. Now, shifting gears a bit, how important is ECMO simulation training?
Yeah, I mean, I would say that ECMO is very amenable to simulation training because it's a high risk, high acuity, infrequent intervention, and particularly in centres that are not busy, which in a hub and spoke model would be, I think, is going to be the majority of centres. I think simulation is essential. One of the great privileges of my career is to have trained for a period of time with Marc de Laval, who's now sadly left us. But he very much pioneered the human factors side of cardiac surgery or congenital heart surgery research. When he was a well-established surgeon, he had a period of time when the outcomes from the switch operation he did were not very good. And so this obviously upset him and made him think, because he was a very smart man. And so he went and looked at all the factors that occurred in the operating room. And he also went and had a period of retraining with one of my other mentors, Bill Braun, and his outcomes came up again. But studying what happened in the operating room for him was quite a seminal moment. And, it's not how you put the stitches, it's things like somebody comes in and starts talking to you about a patient that's on the floor that's deteriorated, or there's a phone call, or there's some other kind of distraction. And so distractions outside the operating room were found to be the main factor in poor outcomes. And so he established a human factors research group subsequently, and I was part of that group. And we looked at various things during congenital heart surgery. But one of the things I got to do as part of that was go and spend a day down at Heathrow Airport with the British Airways training captains who were part of this human factors group, and also to be in meetings with James Reason, who invented the Swiss cheese analogy of error propagation. But when I was with the pilots in the simulator, British Airways pulled these guys off flying their planes to put them in the simulator because they had changed the way that they spoke about engine fires. So instead of saying what they did before, which was engine fire, engine number 4, they had decided that the word fire should become first in the phrase. Mm-hmm. So they said fire, engine number 4. So this was felt to be such an important thing. They put those people who could be earning revenue by flying people around the world in a very expensive simulator for a whole day to get them to do that.
Yeah, that's very interesting.
dainty order of what they said. Now, we are a million miles away from that in medicine. And I think that there are, similarities between civil aviation and medicine, and also between military aviation and medicine, perhaps more so. But I think that we talk about simulation, and it's a really important tool. And we have simulation we run all the time, particularly in our ECPR program in the PCICU, which runs extremely well. But we have got a long way to go before we can match both the technology and also the support for the whole concept of simulation in medicine compared to civil aviation.
Yes, very interesting.
Very much that was 21 years ago
Right.
that happened.
How important is early rehabilitation and early mobility for ECMO patients? I know you had a recent publication on this as well.
Yes, I would say that it's essential. I think the first stage of doing ECMO successfully is to basically get on safely and manage the circuit safely. And by getting on safely, I don't just mean not poking the cannula out, but picking the right cannula that's the right diameter and putting it in the right place so it works. The second thing is, the day-to-day housekeeping. So you have all your protocols so that they allow the patient to recover. So in the cardiac arena, that means venting the left heart. In respiratory ECMO, it means resting the lungs. Then you come to what I call the three pillars of the stool that the patient survival is based on, which is basically full nutrition, liberation from sedation, and mobilization. So, you need a patient walking down the corridor, eating their lunch, and not snowed with sedatives. That's what makes it work.
All right. Yeah, I see you're getting page more. Do you have to get going? Are you good?
Yeah, another couple of minutes.
Okay, got it. We'll wrap up here. But what excites you right now in this field of ECMO, Dr. Peek?
Oh, that's a great question. So that allows me to tell you about nitric oxide in the sweet gas. So one of my early papers looked at, and also my subject of my thesis was the blood surface interaction with the circuit. So basically, exposure of the blood to the extracorporeal circuit causes both inflammation and clotting. And, both of those things are bad. And the worst part of the circuit for causing those things is the membrane, because you have to put the blood through tiny tubes in order to get gas exchange. So that's a downer because of the design of the oxygenator, but it also gives us an opportunity because we can add things to the sweet gas. And obviously, we're used to adding nitric oxide to the ventilator gas, but it turns out it's actually quite easy to add nitric oxide to the sweet gas, which is something that a number of different people have been both doing and investigating. I started doing this routinely about 5 years ago. And my impression is that A, it stops platelet activation in the membrane, and B, it seems to reduce inflammation. So we can offset a lot of the inherent inflammatory cost of going on ECMO. And this patient I was telling you about that we had on ECMO for 8 months, we had her with a single oxygenator for 5 months. And when that came off because she got better and didn't need ECMO anymore, I took the oxygenator, washed it out, and sent it to my colleague Andrew Baczynski in Texas, who's got a lab that looks at oxygenators. And he cut it and spread the membrane out, and it looks brand new. There's not one single adherent clot to it. Now, given that a lot of people are only managing to run their circuits for a week before they change them out, this is quite impressive, really. So we have a research group which is called Snoopy, which stands for Sweet Nitric Oxide Observational Panel Investigators, which is an international multidisciplinary, multi-institutional group of researchers that are looking at this. And we've written several papers about it and review articles and things. But we're going to be running some prospective cohort studies and then ultimately a randomized control trial. So I think nitric in the sweet is the new thing.
That's great. That's great. Fantastic.
So I really need to go now.
Yeah, no problem. Thank you so much for your time, Dr. Peek, for being a guest on MD Roundtable, and I appreciate you being on, okay?
Fantastic. Thank you for inviting me.
Of course. Have a great day. Folks, if you enjoyed that episode, don't forget to leave a review of MD Roundtable Podcast, and don't forget to subscribe. Also, if you want to reach out to me with any comments or questions, feel free to go ahead and email me at drtedthatchandcarey@gmail.com. Once again, drtedthatchandcarey@gmail.com. I will also leave the email contact in my show notes. Thank you again for joining me. Have a great day.